Okay, so we're going to start with new material. Okay, this will be chapter 6, a couple of chapters ahead. But before that, are there any questions at all? Anything I've just said that's just not making sense? Again, remember this is multiple choice. It's going to help guide you the way you study for this test. Right? You don't have to write this out from scratch. Anything at all from any of the chapters before we move on? So what I just did, for those who are listening, I just posted last semester's video since I had trouble with that one. Start from 1 hour, and then I'll post this little short video, the last part, as a separate link. Okay, so bone. Now this is, look at this, the first 8 sections. I'm asking you to go back and look on your own because the first 8 sections are just simply what a bone looks like under the microscope and structures of a bone. This is old stuff. You know bones. And in lab this week, you started looking at bones and bone markings. So I think this is an appropriate place for us to jump into this chapter now. So even though I'm giving you the first 8 modules here in the notes, so let's just flash through this, and as I'm going through this, remind yourself, this is what I want you to be thinking about as you move forward. So you know there's 206 bones, or thereabouts, in your axial and appendicular skeletons together. And the skeletal system includes not only the bones, but also the cartilages and the ligaments that hold all of these bones together. We know what the skeletal system does. We know it's very important not only for providing support, but for storing minerals, specifically calcium and phosphate. It also is storing some lipids as well. Adipose tissue in bone stores lipids. So there's actually some fat in the bones that are important for storing lipid. We know about the blood cell production occurring in many of your bones, and we know, of course, that the bones are there to protect many of your more delicate organs. You know that bones come in many different shapes, and so here are a reminder of those different shapes of bones. And the flat bones, we've talked about flat bones before, like the sternum or the cranial bones. These are the bones that have a slightly different anatomy, don't they? Remember, the flat bones are, they have the diploid. Remember that diploid? And there's 2 layers of bone with one layer of spongy bone in between. Then there's sutural bones. Now, this is not a term I used last semester, so I want to stop and just say this word. The bones that make up your sutures, that is, you know there's 4 or so sutures, and you saw some of them in lab this week. There is a lambdoid suture. There is a coronal suture that you already should know. And these are what? These are connections between your cranial bones. And as those bones grow and as they grow together, if you look at a real skull especially, the plastic ones don't do quite the justice, you'll see this kind of woven area where the bones have come together, and you'll even see little fragments of bone that help fill in the gaps. Those are those little wormian bones or sutural bones, and they're quite variable from person to person. Yes, question?
So then, with those sutural bones, the bones of the skull don't fuse together, but rather they're like glued together?
They're kind of glued together. Those are considered fibrous joints. And they are kind of glued together. That's a good way of thinking about it, by those sutural bones. Yep. And they do come together, right? Clearly they do. And you saw in the fetal skull, you saw the 4 different fontanelles, right? Those soft spots. And it's along, those fontanelles especially have some of these wormian bones, but even along the entire coronal suture, right? You'll see these little bones. So next week when you're in the lab, take a look, or in your book too, it shows it, but take a look at those sutures and appreciate, especially if you grab, if you look at some of the better models, you'll see those little bone fragments, almost like little chips that are making up part of that suture. Then there's the long bones. We spent a lot of time last semester talking about the structures of a long bone, the epiphyses, the metaphysis, all of those things. Then there's those funky bones, the irregular bones, like your vertebra. They're just oddly shaped. And then there's sesamoid bone. This is also a new one. These are small little flat bones. They develop inside the tendons of your knee, of your feet, and of your hands. And there's a variable number of these. Some of you have more or less. And I'll if I don't have an X-ray picture here, I'll try to find one for you of sesamoid bones. But they're in addition to the 206 bones in your body. And there's a variable number of them. And then those little short bones like your carpals, your tarsals, and your patella. So just a little quick picture of it. Now, the patella is actually considered a sesamoid bone itself because it is built into or develops in the patellar tendon, okay, and in the quadriceps femoris structure. So it is itself considered a sesamoid bone, but there are also other sesamoid bones in your feet that are in addition to your metatarsals and your tarsals. You know a lot about these surface markings on bones, so that's what I'm not going to get into. Why do bones have bumps, grooves, holes? Right, for attachments or for the passage of nerves or blood vessels. So every bump, groove, and hole in a bone is there for some anatomical reason, and we'll be learning about. Well, you've seen them all in lab this week. There's probably about I haven't counted them, but there's probably about 25 or so new structures that you are being asked to know in addition to what you knew from last semester. And if you learn all these bone markings, you can listen to CSI shows in a whole new appreciation, right? You can listen to Bones or listen to CSI shows, and they'll pull up these conversations and they'll mention these bone markings in passing. And I always kind of wonder, what did I think about that conversation when I didn't know what these things were, right? You just kind of glossed over the top of your head, but now you can go, okay, now this really makes a whole lot more sense. And they actually do have, for those shows, they do have medical experts who make sure they're not saying hogwash. They usually are saying correct things. Okay, so we know about, the head of a bone. That's usually the more proximal end of a long bone, right? The diaphysis is the shaft, and the neck is the narrow region between the head and the diaphysis. These are all terms you know. So this is what I'm going to have you jump over. If you know a tubercle, a tuberosity, a trochlea, if you know condyle, then when you're learning the bone markings, this will be so much easier. So you're not just memorizing some random structure with a funky name on it. You actually know that a tuberosity is a roughened area where there's an attachment, or trochlea is like a pulley-shaped structure, as is found on the humerus. There's a whole bunch of them, aren't there? Right? Quite a few. Trochanters. The only trochanter we have is on the femur. Facets or facets, small, flattened surfaces. Again, so you know this. You know these words. You've seen them on the bone markings. And then the rest of this is just things you know. Okay, so I'm not going to spend any time here. If I see something you haven't been exposed to, I'll stop. Remember that bones are extremely metabolic, right? They're not just sticks in your body. They have blood flow. They have nerves traveling through them. We will spend a little bit of time talking about fractures today. Remember the cells of bone, 4 types. Osteocytes. Where do we find osteocytes? In the bone, right? They're the cells in semi-retirement. They're in the bone. They're in the lacunae. And we're talking about compact bone here. And they're in those lacunae, in those little spots or those little spaces. Then there are osteoblasts. These are the cells that are actually making the new bone. We would say that they are undergoing they're part of osteogenesis, the making of bone, or the process of ossification, things becoming bone-like. They are making osteoid. Osteoid is the hard calcium phosphate stuff that is making our bones hard. There's also osteogenic cells. As the name suggests, these are cells that are producing. These are sort of like the stem cells. If you break a bone, these cells are going to come to the rescue and help heal that bone, creating new osteoblasts. And then osteoblasts, once they're cocooned in the osteoid material, are then renamed osteocytes, as they sort of, I think of them as being in semi-retirement. Then and those osteogenic cells are going to be lining the periosteum, lining the medullary cavity, and lining passageways containing blood vessels. So they're on the outside and the inside, aren't they? Periosteum on the out of the bone, the medullary cavity, the inside of the bone. So these osteogenitor cells are there in and outside. And then there's those osteoclasts. Remember, they're not at all similar to, they're very different from, they're actually a specialized macrophage, and they are there to clean up the mess. So not only are they there to clean up the mess if you have a fracture, but they're also there for your remodeling. Your bones are not static. They're constantly changing, and there's always a yin-yang going on between the deposition, the building up of bone, the storing of calcium, and the release of calcium into your bloodstream. To release calcium, you must use osteoclasts, right? They're chewing up, they're much, much larger, they're phagocytic, they're producing hydrochloric acid, and pretty cool cells. I was going to say something else there too. Lots of lysosomes, right, for breaking things down. It'll come to me in a moment. So here are the 4 cells. So we've got the osteocytes living in the lacunae. We have osteoblasts on the outside or on the inside making new bone. We have the osteogenitor cells that are hanging out on the inside and outside of the bone waiting to be brought into work if there's any kind of damage. And then those big, huge osteoclasts. I didn't go into this last semester. So the calcium phosphate, the stuff that makes up the inorganic. Do you agree this is inorganic? Calcium and phosphate are inorganic. They don't have carbon. So calcium phosphate, when they come together, make basically stones. And these stones, calcium phosphate, are making up about 2/3 of your bone weight. Now, what's the organic portion of your bone, primarily? If the calcium phosphate is making up the inorganic, the organic portion of your bone, the protein, the major protein of your bones are?
Carbon.
Protein. What protein gives your tissues strength? Collagen, right? So you're going to have a lot of collagen. That would be the protein component of your bones. We would say that is the organic component of your bones. And the calcium phosphate can form what's called hydroxyapatite. It's kind of a cool word. But this is what really is providing strength to your bones. So your bones are really like concrete, right? They're a combination of an inorganic mix along with some enforcers, some steel rod enforcers, sort of like what calcium or what collagen does for your bones. And then we think about the histology of bone. This is old, right? We should know osteons, canaliculi. We should be okay with lamella, those terms. So I'm going to skip right through that. And then there's spongy bone. Now, only thing we looked at last semester was compact bone. We did not look under the microscope at spongy bone. Remember, spongy bone is in the areas of the bones that are less needed for support. They're more internal, and they aren't arranged in osteons, but instead in trabeculae. And trabeculae is a word meaning kind of like this mazy area, and it forms this network. This airy network reduces the weight of the skeleton and allows, this is also in the trabeculae where your bone marrow is found and where your blood cells are being produced. Okay, and bone grows. We know bone grows in a couple different ways. Bone grows longer, bone grows larger in diameter. Larger diameter is appositional growth. Okay, so this is a bone, it gets bigger in diameter. You know your bones get bigger in diameter from the time you're a baby until you reach your adolescent years. That's appositional growth. So growth is going to be occurring, and these osteogenic cells are making more osteoblasts. Those osteoblasts are building and building and building, making more layers. They're making more lamellae, right? And all those osteoblasts are getting caught up in the hydroxyapatite and in the osteoid material, and then we call them osteocytes. There is a constant remodeling of these structures, and so even once you make bone, it is not static. Like I said earlier, you're going to be releasing calcium, and, oh, that's what I was going to say. We've been talking about calcium quite a bit, haven't we? So in order to have good neural structures, neural function, you have to have osteoclasts, don't you? Right? You have to have osteoclasts to release the calcium so that your nervous system can work, because without calcium in the right places at the right time, you can't release neurotransmitters from a synaptic knob, right? So you have to have those calcium-gated channels, and you have to have the calcium coming in, binding with the synaptic vesicles for the exocytosis of those neurotransmitters.
So when the osteoclasts break it down and release the calcium, is that picked up by the bloodstream?
It is. So as the question was, where does that calcium go? So when the osteoclasts chew up the bone, it is released, They're releasing hydrochloric acid. That acid is breaking down the hydroxyapatite crystals, and then that's being released into the bloodstream. And that's where I'm heading. Where I want to get past this introduction stuff and get into the calcium regulation and the hormones that are regulating that calcium. Okay, so that's where we're heading. But I want to just quickly breeze through bone stuff that we have learned before but may not be fresh in our mind. So, of course, bones get bigger around. That's the appositional growth. Keep on going through this. There's an endosteal layer and a periosteal layer. And then there's also endochondral ossification. This is the type of bone formation where you once had, as it suggests, endochondrial within cartilage. So this is where you start off with a hyaline cartilage model, like most of our skeleton is, and then becomes bone. And that process is called ossification when something comes more bone-like. So we've been through those stages before. I'll let you look at that yourself. And I believe that brings us up to where I wanted to go. So this is a little 10-week and then 16-week little fetus. And you can see if there was enough light behind that, those bones are extremely red, right? Lots of blood production going on. And even through the entire length of those long bones. See all the red? So there's red, there's blood going on. But they're also quite translucent because we're still dealing with some hyaline cartilage in this. Now, as we become adults, there's less and less red bone marrow. So the red bone marrow is not in our entire femur. As an adult, it is restricted just to the proximal head. And we only have bone marrow in our proximal head of our humerus. But as a young child, and certainly as a fetus, you can see that the entire length of the long bone had bone marrow in it. During this time, there's a huge amount of hematopoiesis going on, right? Lots and lots of blood cell production going on. Okay, so I think that's where I want to bring us up to. Did I see at the very first slide, go through 1 through 8 on your own? 6, 1 through 8. So let's start with 9 here. This is where I want to pick up with new material, slow down a little bit. If now, we're not going to be looking at this for a while. On next Tuesday, we'll have a test, and then next Thursday, we'll pick up with the rest. It's more content. But certainly, there can be issues with bones, and one of those issues can be a pituitary growth failure. The pituitary gland, if you remember, and this will be tying in with one of the other chapters on this next test on the endocrine system. And do you recall what hormones the anterior pituitary makes? Or any of them at all? We talked about the posterior pituitary, right? Back in water. It doesn't make anything, but it releases oxytocin and ADH, the ADH story you know. But the anterior pituitary releases 6 or 7 hormones, one of which is growth hormone, right? And there's also FSH, and there's a few other ones, LH. But growth hormone is what I'm worried about here. And so if there's a pituitary issue, there can be, if there's a lack of growth hormone being produced, that can lead to a shortening of the bones and lead to someone being rather short, okay, abnormally short bones. Now, this is rather rare in our country because nowadays we can give somebody, if they're really, really short, we can give them some synthetic growth hormone. Now, that would be only after a diagnosed pituitary issue. I recall years ago I had a student when I was teaching middle school and high school, and he was just a really short kid. He was below the 5th percentile for all the growth charts. But his parents were also very short. And they didn't want a short child. And so they were injecting him with growth hormone. They found a doctor who was willing to inject him with growth hormone. I'm not sure that's the most ethical thing, right? If the parents were really tall and the kid was really short and maybe had a pituitary issue, that'd be one thing. But they were small people. This kid was small, just like they were. And they were giving him growth hormone. And I never saw him much later to know if it really made any difference because there wasn't a deficit, right? There wasn't a deficit in growth hormone. He was simply genetically a short person. But there can also be achondroplasia. Now, this is a different condition. These are what the other condition, the total growth hormone, would make people of normal proportion. So just take, like we're going to be getting some little skeletons. It'd be like a regular skeleton just shrunk down if there was a growth hormone problem from the pituitary gland. But this is a different issue. Achondroplasia is a specific genetic condition where the epiphyseal plates of long bones grow very shortly, but their trunk is of normal size. So these folks have normal trunks, but very short arms and legs, very short appendages, and no effect on any other point. So now we have TLC shows, right, with these folks. Now, Marfan syndrome, this is another issue that causes lengthened bones. So Marfan's is another inherited disorder, and here there's an excessive cartilage formation that results in a very tall person, and they also have some other connective tissue disorders. These folks typically have issues with cardiovascular because with that so the cartilage, bone, the structures are more elastic, and typically the heart is also negatively affected by this. There's evidence that Lincoln had Marfan syndrome, right? Very tall, lanky person. So there's evidence. I don't know how definitive it is, but I've seen some TLC history type shows that suggest that he may have had Marfan syndrome. He had that characteristics. And then there can be also giantism, and this would be where the long bones continue to grow. And this would be an overproduction of growth hormone before puberty. This has to be before puberty, right? So I talked about pituitary deficiency, short people. Now this is an overproduction, typically a tumor, and it's happening before puberty. Why is it important that this tumor is in place before puberty? What happens at puberty and throughout the adolescent years? The bones, the epiphyseal plates close, don't they? And so this disorder, to have the giantism, would have to be young pituitary problem, and the bones keep on growing. They never have that epiphyseal plate phenomenon, and they keep on going. And these are the 7-foot giants in China, right? This guy, you see him in all the world record books, 8 feet 11, right? Now, you can imagine how difficult this is on the joints, on the cardiovascular system, but this is most definitely going to be a pituitary tumor. Nowadays, they can go in there and either suppress the growth hormone release or radiate the heck out of that pituitary. And where would they be aiming? What bony structure would they be aiming for to radiate that pituitary gland? The cella turcica, right? Part of the sphenoid bone.
Now, is it a cancerous tumor?
It could be.
Okay.
More than likely more of a benign, right? Something that's just growing out of control, and it's growing or causing just an overproduction of the growth hormone cells. And then finally, there can be Shrek, right? Acromegaly. So acro means extremity, or the extreme end, right? Acro, extreme end, megaly, enlargement. So this is a condition of a pituitary tumor after puberty. The epiphyseal plates have already fused. There's no more elongating of the long bones, but there is an abnormal thickening of the face, the jaw, and the hands, right? So you get these big faces. It's Shrek and, is it Fiona, Liz's girlfriend? Right? So this is Shrek and Fiona, right? Or Andre the Giant, right? Princess Bride. Who was that? Was that Andre?
Yeah.
Right? So that big, that big face, big hands kind of thing, that's acromegaly. Okay, so again, it's a pituitary overgrowth post-puberty that doesn't elongate the bones. And then there can be FOP. Now, FOP is a genetic disorder where bones continue to deposit inappropriately. Think about your bone box. When we do bones, you can recognize the femur. You can recognize the scapula. You can recognize the bones. They all have a distinct shape. Even if you look at 100 different skeletons, you'll still figure out which bone's the femur. They all have the same shape. All the bone markings, all the structures are there because they were necessary for normal anatomy and physiology. But in this condition, there's an abnormal deposition of bones in very unusual places, what you would say ectopic, right? An ectopic pregnancy where the embryo plants out of place, and ectopic placement of these bones. And there's no treatment really known for this, and the lifespan is affected depending on what structures are affected. But here's a skeleton of a person, and you can see all of this. I know it's hard to see, but this does not look like a normal bone, right? There's definitely, look at this elbow area, right? All sorts of extra bony structures being made, and down in the sacrum as well. And so very difficult, very rare, but you can watch some TLC shows on these guys. Sorry about the overlap. And then there's also clubfoot. Now this is this congenital. This is, what does congenital mean? Congenital means you're born with it, right? Now this is somewhere around 2 in 1,000 births or so, and mostly boys more than girls, and it can affect 1 or more feet. It's from mild to severe, but usually just club feet, really turned in. A lot of this has to do with the positioning of the baby during development, and the feet are crowded, and as the feet are growing, as those long bones are growing, they really don't have a place to go, and so things get turned in. And so these kids wear casts or special shoes as young children. It's usually resolved, no problem. But again, if the skeleton can't develop, if it's a very small mother or a very large baby and things can't turn well, then that can happen. I wasn't ever given this diagnosis, but I know that as a kid I wore special shoes. That's what I remember my mother saying. And I was a big baby. So likely I had that same sort of clubfoot thing in. So I just remember I don't remember it, but I was told I wore special shoes for the first couple of years to help correct my feet.
Saying that, like, pulled her legs up and made it look like a frog.
Yeah, stuck out.
Okay, so that's sort of anatomy. A few disorders kind of make it interesting. Now, this is where the real meat and potatoes are of this presentation. I've got about a half hour that should do it. We know that bones store minerals, and as you can imagine, calcium is very important, as we already know, for action potentials. We're going to see for exam 3 that calcium is also critically important for muscle contraction, and calcium is important for blood clotting. So these are all pretty important processes. We need to get the calcium out as needed, and we need to store it as needed. So you can imagine there's going to be some negative feedback going on here and some sort of control for this calcium release. We already know the cells. We know the osteoclasts that are releasing the calcium. We know the osteoblasts that are building the bone, but we've never talked about when do the osteoblasts get turned on and when do the osteoclasts get turned on. So there are going to be some hormonal signals that are going to kick in to balance the building and release of calcium. So we've already mentioned the mineral content of bones, right? There's an inorganic part. That inorganic part is also contributing to your osmotic balance. Think about it. Calcium, the hydroxyapatite was calcium and phosphate. We saw in passing calcium and phosphate in our external and internal fluids, didn't we? Remember, they were on the charts. There was calcium and phosphate next to chloride, potassium, and sodium. And so remember that calcium and phosphate, therefore, would help with osmotic balance. So more than just bones, right? Calcium and phosphate are also important for osmotic balance as you think about where water is going to be as solutes suck. And I've already talked about the physiological processes that are vital. We've already mentioned 67-33, so about 2/3 inorganic, that is calcium calcium and phosphate mineral salts, and about 1/3 organic, primarily collagen. Your bones at any one time have about 99% of your body's calcium locked up within them. So we've got to store this calcium and release it as needed. So a quick little chart, bone composition. All I want you to see, lots of calcium, right? Lots and lots of calcium and lots of phosphate. Those are the two big ones, aren't they? Calcium, phosphate, calcium, phosphate. That's the inorganic portion. Oh yeah, there's some magnesium, yeah, there's some potassium, there's some sodium, but calcium and phosphate are the two big ones. And then the 1/3 of the pie is the collagen, the organic molecules. And then the other thing I want you to appreciate is that most of your calcium, like I just said, is locked up in your bones. 99% of your body's calcium is there. And phosphate, right? So again, calcium and phosphate are both locked up together in the bones. And I've already told you that you never want calcium and phosphate loose in your tissues, because when they're together, they make bone, right? That's what they're best at. So they grab each other and make these calcium phosphate crystals, these hydroxyapatite crystals. So you want to release calcium and phosphate, but under very controlled ways, so that you don't get kidney stones, so you don't get liver stones, so you don't have crunchy arteries, which is also a buildup of some of these molecules. Okay, so calcium supplementation is important, especially for women past about the age 30, 35. For guys past the age 40, 45, calcium supplementation is pretty important, but not too much, right? Not too much. Too much can lead to homeostatic problems, and you'll start having some kidney stones. people who all of a sudden, you know, think they're going to get healthy and start taking supplements, sometimes will a year or two later have kidney stones. They've overdone it. So not only were they taking supplements, they were also having their yogurt and their slice of cheese, and they were just overdoing calcium, and that can be problematic. Now, where are we going to control our calcium levels? Much of it's our diet, right? So what comes in is going to come in through our diet. It's going to be absorbed through the intestines. This absorption will be under hormonal control, and we'll talk about those hormones as we get through this evening. The bones are also going to be grabbing this calcium. The osteoblasts will be using it to make new bone. Here it says new matrix, right? Bony matrix. And the osteoclasts are going to be releasing calcium as needed. And the kidneys are also going to be under hormonal control to help release or not release calcium. So we'll see hormonal control at the absorption. We'll see hormonal control at the excretion. And we'll see how the bones are also being told to store or not to store this calcium. So just looking at a quick picture, again, normal calcium coming in your, this is in your blood vessel. So normal calcium levels, depends on how much you take in, how much you let go, and the interchange of release and building of your bones. So the two hormones that are critically important, actually three. First one, parathyroid hormone. Major player. Not hard, it's made by the parathyroid gland. Where is your parathyroid, I should say glands. Where are your parathyroid glands? On the back of the thyroid. So they're posterior. Usually 4, 2 on each side. Some people just have 1 on each side. Some people have 3. It's these little patches of cells, very small glands on the posterior side of your thyroid. They are releasing PTH, and here's what they do. Their responses in the bones, they're going to tell the osteoclasts to erode. They're going to tell the osteoclasts to release calcium. So you tell me right now, why is parathyroid getting turned on? If parathyroid is going to tell the osteoclast to get busy and start chewing up to release calcium, that means that parathyroid must be released in response to low calcium, right? So on the top of this page, put big old low calcium. So when calcium's low, we're going to release PTH. So it's going to tell the osteoclast to get busy, chew away the bone, release some calcium. It's going to tell the intestines to go ahead and increase the absorption from the diet. There's another molecule, calcitriol, that we'll see here in a few minutes. It's also going to tell the kidneys, when it gets more of that calcitriol, it's going to stimulate reabsorption of kidneys. What does that mean? Rather than excreting it, the calcium will be reabsorbed, taken back up. So as a result, what's going to happen? Parathyroid is going to tell the body to restore, right, the calcium levels back to normal. So we got parathyroid hormone. And here's just a cartoon of that. And here it tells you low calcium. Low calcium. So if you have low calcium in your blood, you have receptors on the parathyroid gland that are looking for those calcium levels. If they're low, we tell the bone to chew away, we tell the intestines to absorb more, and we tell the kidney to hold on to it. Right? Kind of makes sense, doesn't it? As a result, we restore the calcium levels in the blood back to normal. Now the other hormone here is calcitonin. Calcitonin, when I hear this word, calc, right, calcium, tone, right, tone, keeping the tone of calcium. Calcitonin is, it ends in IN, it's a protein. It is a hormone released specifically from cells of the thyroid gland called the C cells. Well, that's easy, C cells. Don't say it too fast. C cells, seashore, right? C cells made by the thyroid are making calcitonin, and they're going to be responding to too high, right? So you're going to be releasing calcitonin when your calcium levels are too high. So what's that going to tell? It's going to tell your osteoclast to quiet down and tell your osteoblast to go ahead and keep building, right? Take the extra calcium and store it. It's going to send a signal to your intestines saying, what? We don't need it, right? Don't absorb it. Let it continue through in the feces. And it's going to send a signal to the kidneys telling them to go ahead and don't reabsorb, but instead release more of the calcium. It makes total sense. So here's a picture of that yin-yang story. So again, a high calcium Okay, about 11. 9 to 10 is normal. So about 11, we start getting calcitonin secretion, and that's going to do what I just said. Okay, so you got a picture here to tell you with this. So the major job, I mean one of the many jobs of the skeleton is to help maintain calcium homeostasis. And clearly if you don't have enough calcium, over time it will negatively impact your bone strength and the ability of bones to work. So if you don't have good calcium, you have osteoporosis, things like that. Pretty straightforward, right? I like this chapter. I think it's a nice, straightforward chapter. Just got to learn a little bit about parathyroid and calcitonin. It's not too bad. Now, when bones get broken, we talked a little bit about this last semester. I gave you some of the story. I'll give you a few more examples here. When there's a fracture, some sort of mechanical stress on the bone, and as a result, the bone is broken, usually everything is restored quite nicely. Remember that bones have on the outside some endosteum and some periosteum on the outside, endosteum on the inside. And along those layers, remember that's where the osteoprogenitor cells are. So if you break the bone, those cells come into, those stem cells kick up, they make more osteoblasts, and the osteoblasts start fixing it. The osteoclasts are also there, and they're going to do what? Eat up the mess, right? Clean up the mess, and so that the builders can start from fresh. So when you have a fracture, there's going to be a hematoma. A fracture hematoma, that's just what? Oma is like a tumor, a big mass. Hemato, blood. So a big bloody ball, right? And it's a big clot. It's going to form rather quickly. Then there's going to be a callus. And there's going to be two calluses, an internal and an external callus. The internal callus will be along the spongy bone. Okay, and that'll help reunite the inner edges of the fracture. And then the external callus will be more of the cartilage and bone from the outer edges. The names kind of tell you. There will then be some spongy bone formation. So the spongy bone will be the first thing to form. There will be some cartilage that comes in. That'll be replaced by the spongy bone, and then eventually the spongy bone will be ossified as well. And that's going to hold everything into place. And then lastly, you have the compact bone coming in. So you'll have the spongy bone being replaced by the compact bone, and over time, remodeling. So just like your bones are always changing, after a fracture, you hold them together, you hold the bones together for 6 or 8 weeks. You know, keep the cast on there, keep the pins, keep everything kind of still for 6 or 8 weeks. The body will naturally kick in and repair that. As long as the two ends of the bones can touch each other, they typically will find each other and repair quite nicely. When they can't touch each other, right, that's when we're having to put plates and pins in and fake bone and other things to bring the pieces together. But the bone is pretty amazing at regeneration. So looking at a picture of it, again, we break this bone. What bone is this?
That's the humerus.
Looks like the humerus to me, right? So I got a little head up here. What's this big bump right here called? The greater tubercle. What's this little bump over here? The lesser tubercle and the groove right down the center. The intertubercle sulcus or groove. Right, it's on the list. It's on the list. Down here, what do we have? Where the ulna sits on here, that would be the trochlea, and the little rounded end over here on the other side would be where the radius kicks in. That's called the capitulum. Good. So anytime I see a bone marking, I'm going to say it for the next couple of weeks until we get them. So we've got this big fracture. We've got some pieces in here. On the inside, you can see, all right, this is the spongy bone on the inside. Then we got some compact bone. And there's been a fracture. There's that big hematoma that's forming. Then we're going to get some cartilage occurring. There's an external and an internal callus that's going to form. And eventually, we're going to have some spongy bone coming in. And eventually, it'll be formed to compact bone. Under an X-ray, you might see that external callus where the fracture was. You might see a little bulge. That's what doctors are looking for. If there's a kid that comes in with any kind of child abuse and they have a broken bone, they're going to take a look on the bones to see if there's any evidence of previous fractures. And they can see those. Newer fractures are really obvious. Older fractures, they can see perhaps a little bit of a difference in the outer edge of the bone. When you break a bone, two basic types, closed or simple. Okay, now these names are deceptive. Closed, that makes sense, right? The bone did not break open. It did not break through the skin, I should say. The bone is broken, right? It's a fracture. Closed or simple. Simple just simply means that there's no break out of the skin. It does not suggest that it's a simple repair. Okay, you can have a very messy fracture that doesn't break through the skin and would still be considered a closed or simple fracture. Then open or compound, that does not mean that it's compoundedly more difficult. Compound simply means that the bone has protruded out of the skin during the damage, during the insult. And these are far more tricky because you've got the issue of infection and bleeding at the time of injury. Okay. Transverse fractures, we saw this before, just simply means that the cut's kind of right along the long axis. A spiral fracture, one where at the time of the damage, the person was in a rotating trajectory. So maybe a gymnast landing after doing a trick, or somebody like a basketball player going up and being in a twisting motion as they come down. That will translate into a spiral fracture. And these are also another type of fracture that they're worried about for child abuse, because the people who twist the arms, right? So that will cause a fracturing, a spiral fracture. So if you have a kid that goes in with a spiral fracture and they were doing gymnastics, you still may have CPS coming to visit you to talk about why your kid has a spiral fracture. And then displaced simply means that it's in a new or abnormal arrangement, and non-displaced fractures will retain their normal alignment. So if it's a displaced fracture, right, it's out of place, it's not going to just magically go back into place. So if you visit less developed countries, you'll see people who have had a fracture who didn't get any kind of orthopedic support, and the bones have healed, but in a very strange angle. So they may have, the scapula and the clavicle in a weird arrangement sticking up. My mother, many years ago, she got T-boned. Car came through and hit her on the side, and she went to the hospital. They x-rayed her shoulder and didn't see a fracture through all the inflammation. She went home. It was painful, but years later, she had this funky little bump on her shoulder, right? So clearly she had a displaced fracture that was never repaired properly and led to a sort of a souvenir moment, right? She had this crazy, and I have a reminder too of a skiing accident years and years ago in Colorado. So I remember jamming my hand going down and didn't think anything of it. But now I have this really weird bump on the back of my hand. So I clearly broke a metacarpal, no doubt about it. But didn't have any, it just hurt like heck. But I didn't see any doctors for it. And clearly they grew back together and it's functional, but it doesn't hurt. But I definitely have a weird bump on my hand as a result. So that's my reminder of skiing. Compression fractions, simply, compression, pushing them together. This could be under some sort of stress. This is going to be more common with people with osteoporosis because the bones are already more brittle, more likely to be compressed. Green stick fractures, as the name suggests, are an unbroken, complete, where the fracture is not complete. It doesn't go all the way through. Other books will call this an incomplete fracture. And so if you take a green stick and you try to break it, right, it doesn't snap, it just kind of bends. And that's what's happening to a bone in a green stick fracture. And then comminuted fracture simply means that it's shattered. It's shattered into many pieces, and likely a comminuted fracture is going to require some extra help. Epiphyseal fractures are occurring where bone matrix is calcifying. This is in that space in between the epiphyseal plate and the cartilage. There's Pott's fracture. This is the bimalleolar fracture. This is when the ankle, and it affects both the medial malleolus and the lateral malleolus. Can you picture that?
Good God, no.
Can you picture the malleoli?
What would you do?
Okay, so this is so both of those little, malleoli coming down on each leg are broken as a result of this. And then Cole's fracture. In other words, there's a name, there's a orthopedic name for many fractures, depending on where it is. I'm not going to go through the whole list by any means, but there's a specific name for a break on the distal radius. Okay, the Cole's fracture. So let's just take a look at a few of these. So Oh, what's the one? So coming into over here, what do we see? Lots of little pieces, right? What bone is this? Can you see it well enough to see? Yeah, there's the head of the femur. There's the neck. This big bump is the greater trochanter, and this is the lesser trochanter. And a little bit distal to this, there's been a break. It doesn't appear to have gone through the skin, so it's still a simple or closed fracture, but it definitely has many, many pieces. And without any, I mean, this person's not walking, right? And they're definitely going to need some pins and rods and maybe go in there and even surgically remove some of those pieces if necessary. Here's an epiphyseal fracture. You can see that we're breaking off at where the epiphyseal plate is. If you imagine, especially at the head of the femur, right, there's a big chunk of bone up at the epiphysis. You can imagine that separating out. That'd be an epiphyseal fracture. Here's, again, you broke off the little end of the radius in this one, or in the Potts fracture. This is the talus. Supposed to be, right? So there's the talus, and you should have the tibia and the fibula kind of coming down on both sides, and the little malleoli have been broken off on both sides. So if it can be done, right, you just imagine breaking your bones. Now, what's going to lead to bone fractures other than just crazy things, trampolines and car accidents and falling? Osteoporosis is the big one. And we've all heard of osteoporosis. This is really a condition of the spongy bone, okay? It's not the outer bone so much, but it's the inside bone, that trabeculae, that maze of spongy bone that is mostly affected. In fact, that's where most of your metabolism is going on. A bone, let's think about this for a second, compact bone has osteocytes. Those osteocytes are kind of cocooned in those lacunae. Yeah, they're metabolically active, but not tremendously so. Most of the metabolism of your bone cells is actually happening in the cells of your spongy bone. And this is where you start having changes over time. Kyphosis, right? If you start having problems with your minerals, kyphosis is the big hump, and it's the deformity of the vertebral, of the vertebra of the thoracic area. And if you also have osteoporosis or having issues with bones, there can also be problems with loss of mobility. The last time I saw the statistics, I don't think they've changed much. I don't want to misquote this, but I think I saw that people who break a hip, right, and who are really have a lot of osteoporosis and are very immobile afterwards and aren't healing very well, is it 60 or 65% of people are dead within a year? Yeah. Okay, it's pretty high, right? So after that hip fracture, it's not just the hip, right? Now this older person who's already got some issues is now very bound, and it leads to, they're not breathing deeply. That leads to pneumonia changes, thrombosis, blood clots from not moving around. So there are a lot of issues post breaking a hip that aren't directly related to that bone, right? Just it's the complications thereof. Estrogen is also another issue with osteoporosis. Estrogen maintains the density of the bones in both men and women. Men do make some estrogen. It's a real problem, though, postmenopausal. At that point, there's a lot less estrogen being made by women, and estrogen inhibits resorption by osteoclasts. What's that word resorption mean? Resorption is they're chewing away, right? So the estrogen keeps the osteoclasts at bay. At menopause, what happens? Less estrogen, the osteoclasts now can start surging, and they can start chewing away, resorbing more bone, and that can lead to some osteoporotic changes. So a lot more bone loss after menopause. So that's why women are choosing to have supplements, right? Have estrogen. Women are having estrogen supplements. But what's the problem with estrogen supplements for some? What's the other problem with estrogen? It's good for your bones, but it's bad for breast cancer is one of the big ones, right? Some breast cancers love estrogen. They're actually turned on by and are fed by estrogen. So there's a balancing act between postmenopausal having estrogen levels, or taking in, having estrogen, the balancing act between osteoporosis and the potential for cancers.
For the cancer, does it have to be like an
Well, I don't know if it's too much or just, I just know that there are a lot of breast cancers that are they just are turned on by and activated by estrogen. And that would not have been as much of a problem if the woman was not on estrogen replacements,
Okay.
on hormone replacement.
They linked prostate cancer.
Prostate cancer, I'm not going to, yeah, certainly not just breast cancer. Yeah, absolutely. But men aren't going around getting estrogen replacements, right? So,
No, it's testosterone.
but yeah, that testosterone story, those patches, we're going to wait and see about 10 years what starts sprouting out of those guys taking testosterone replacement. Okay, so what can we do for osteoporosis? Yes, we can give you some ERT, some estrogen replacement therapy. That's going to slow down the bone resorption, but there it is. It's not only increasing your chances for breast cancer, but also stroke and heart disease. So there are a bunch of diseases, or a bunch of drugs, Fosamax, Beniva, there's a bunch of them out there, Actonel, and they basically all work by destroying osteoclasts. You can also give somebody PTH, right? PTH will slow the bone loss if given. The problem is you have to give it almost every day, right? So it's not an easy treatment. But parathyroid, what would parathyroid be doing? Let's think about it. Why would parathyroid be an effective, potentially effective treatment for osteoporosis? PTH was released when calcium levels were too low. Okay, and what did it do? Encourage the building up of, right, too low. So what were you doing? Absorbing more calcium and holding on to more calcium through your kidney. So by giving PTH, you're actually hopefully encouraging, the rising of calcium levels in your body and helping with this a little bit. So the best thing you can do is prevention, and you'll hear this over and over, especially ladies, but once you start having bone issues, it's kind of too late. So the best thing you can do is eat healthy and exercise and have good bone strength so that as you do age and as bone does become more porous, that it becomes less problematic later on. So if you start off with good, strong bones, it'll be a lot longer before you start having issues. So here you're looking at osteoporosis. Look at this, you're inside the spongy bone. This is that trabeculae, right? And we're looking actually at spinal osteoporosis. And this is, just look how brittle this bone is. Very, very brittle. So it doesn't matter where it is. That's just the trabeculae, and you see how brittle that spongy bone is becoming. So we did finish up that content. So let me tell you what's coming in the last 1 minute. The chapter that everyone is most challenged by, I know you're not thinking about it right now, but after we do this test, the endocrine chapter is the one that really gets people a little bit out of shape. This chapter was straightforward. We mentioned calcitonin and parathyroid, big deal. We already know most of this. When we get to the endocrine chapter, I will be presenting to you 20, 25 hormones, and those hormones and what they do and what targeting they're doing. And it's quite a bit of information. That's the big chunk of the next test. And then the other section is autonomic nervous system. Honestly, what I'm going to ask you to know about the autonomic nervous system this semester is a smidgen more than last semester. So it's not a much greater conversation. So it's going to be the endocrine chapter, just telling you, it's going to be the endocrine chapter that's going to give you the most concern in exam 2. So with all that said, I will see you all on Tuesday. Email me if you have any specific questions. Remember, I gave you 3 questions to work on, and statistically you have to do all 3 if you want to do a bonus question, and I certainly encourage you to at least attempt a bonus question.